Thank you, everybody, for being here today. As Sue had mentioned, my name is Robin Deppenbrock. I'm the Director of Agency Services at Pivot Health. I'm going to go through our current portfolio of short-term products with you, kind of let you know what makes them different in the market and where they're available, as well as provide you with information on our newest products that we've just launched in the last month into the market that I think you'll find very innovative and to be something that is going to be great to be in your portfolio. First, let's just talk a little bit about who's Pivot Health. Pivot Health is not an insurance company. Pivot Health is actually a marketing arm of the insurance company. So Pivot Health comes up with the product, they develop the product, they take it to relationships that they have in the insurance space, and then they bring that product to distribution or to market. So Pivot Health launched in 2016 with the individual short-term products, and the insurer behind the product is Companion Life, A+ rated carrier, been in the market for over 40 years. The administrator of our product is Allied National. They've been in the market since 1970, very strong administration, TPA, and so we have a very strong backing with our TPA, our Companion Life insurance company, and then we've taken that product and now we're bringing it to distribution to the market. Even though the product is fairly new, started in 2016, our team of leadership has been in the market for a long time. Our founders have started and sold companies that have been in this market space. They're still in the market space. They manage over $7 billion in insurance premium. So very sound leadership with the backing. Just to give you an idea of our growth, remember I said our product launched in 2016. It launched right around open enrollment time. And so in 2017, our revenue was about $5 million. 2018, our revenue grew to $44 million. So big growth over the past year and a half. And then also this year, we're looking to even grow it further. So let's talk about our products. We've got 3 products kind of tailoring to different stages of life within an individual. One is our core plans. Now, these plans are fairly new. They rolled out, I believe, the summertime of last year. These plans are for your young individuals. They just want to know they have insurance. You know, they're just starting in the job market. Maybe they're still in college or going to get masters or doctorates or whatever, but they just want to know, gosh, I can go to the doctor and have a copay, and I don't have to meet these gigantic deductibles before I can use my plan. But I don't really need a lot of coverage. I never get sick. So we created these plans for that generation, that younger person who maybe it's just themselves, and they just want to know that they can go to the doctor. This is tied to the First Health Network. It allows child-only plans down to 6 months, and it has it's more of a limited plan, and so it has some fixed hospitalization benefits, which we'll go through real quick. The classic plans, these are your more comprehensive plans. These plans have doctor office visit copays. They have RX coverage. Again, they cover child-only applicants down to 6 months. They use an open access or no network restrictions, and there's multiple duration options on these plans. These are the plans that we're selling the most of. Then our brand new to the market is our Bridge to Medicare product. This product is exclusively for individuals that are 62 to 64 and 11 months. We issue 3 12-month plans at one time. There's no new underwriting for policy 2 and 3. There's no new pre-ex look back for policy 2 and 3. So once that person has that Bridge to Medicare plan, they are covered for 3 years. There's an RX rider benefit on it. It's a lower rate than ACA, and it also gives you as an agent a longer lifetime value or a higher lifetime value for that client. So real quick, the classic plans, if you're not selling them today or you haven't seen those, there's basically 4 plans. designs, excuse me, you'll see that there's multiple options within each plan design. These 4 plan designs gives you about 37 different plan options, so that you can have a deductible, you know, whether you want a lower or higher, and that can depend on the premium you're looking for. We have plans that have doctor office visit copays. There are 3 per person, per policy. And then we have 2 plans that have the prescription drug benefit, where on the deluxe plan, you'll see it is a $10 for prescription drug per generic, and then you have to satisfy a $500 deductible before you get your brand and your non-preferred drug copays. We have 2 plans that have $1 million maximum coverage. And just to give you some insight, our choice plan at a $5,000 deductible is our top selling plan with $1 million coverage max. Uh-oh. Sorry about that. Okay. So those are our classic plans. The core short-term plans, these again are those plans, the deductibles are low. There's a doctor office visit copays, the same 3 per covered person per policy period. This plan, one plan has a discount card, another plan has the RX rider on it. You'll see the generics for a copay of $10. And then there's that $500 deductible before the preferred and brand names copays kick in. This is tied to the First Health Network. And you'll see here the outpatient and inpatient care that gives you a $1 limit per day. So we kind of made this a lighter plan, but it has the network. So you might have someone who's stuck on, I need to have a network. Here's a network plan for them. There are 2 options. There's no variables within those 2 options. This is $1,000 or $2,000 deductible, and those are the 2 plans. So this is our kind of our skinny down version, although it is tied to the First Health Network. So what makes these plans different? Again, it's the array of plan options and the duration options that I'm going to show you in a second that makes them a little bit different. The plans include prescription drug coverage, doctor office visit copays, and up to $1 million max. Coverage starts as soon as the next day. So when you're going through an application with your insured, or your insured does an application, once they do an e-signature, the next email they're going to receive is their welcome email to download their ID cards. Everything is electronic. Enrollment's electronic, and fulfillment's electronic. So there's no back and forth and verification. Basically, once they e-sign, they're ready to start their plan. We do, again, accept child-only applications starting at 6 months. We also accept children only on an application, and you would put the youngest child as the primary, and then the other children from youngest to oldest as dependents. We cover high school and college athletes. Again, the core plan is tied to the First Health Network. And the classic plan, not classics as I see here, the classic plans have no network restrictions. It's freedom of choice. An insured can choose any facility or doctor that they want to go to. And what Pivot does is they pay what we call Medicare Plus. Or if you're in the group world at all, you might hear reference-based pricing, usual and customary. So what Pivot does is they pay 150% of Medicare allowable to facilities and up to 125% of Medicare allowable to physicians and professional services. So what does that mean? So basically, the insured will receive an ID card. The reimbursement's right on the ID card for the facility and for the doctor. On the back of the ID card, there's a benefit verification line. We urge agents to tell the insured to have their provider call that benefit verification line. They would call and verify benefits on any network. So it's the same process that they would go through. So they're going to call Allied, who's our plan administrator, and Allied's going to tell them how they file claims, what to expect, and what they'll be reimbursed. They would file a claim like any other claim. They can either mail it to Allied or send it EDI. Once that claim is received, it will be repriced based on the reference-based pricing or the Medicare Plus pricing. The provider will be paid, and then the insured will be billed based on deductible and coinsurance. So what happens here is that the discount that everyone's used to saying or hearing, the discount that's applied to those claims equates to about a 60% discount. So the insured is paying, on average, a little bit less out of pocket based on that reimbursement. But what we also offer is a no balance bill guarantee. So we don't have contracts with the provider, so we can't guarantee that an insured is not going to receive a balance bill. But what we do say is if they do receive a balance bill, that they send that balance bill to Allied, and Allied will negotiate that balance bill with the provider and come up with a reasonable rate for that service. Any money that Pivot has to pay above what they've already paid on that negotiated rate, Pivot pays. The insured is not responsible. So now the insured is winning because now they have no balance bill guarantee. And to be honest with you, providers are accepting the Medicare Plus because they're getting more than what they would get if they're being paid Medicare. Typically, we are seeing about less than 1% of any balance bills that come to us that we're negotiating. Typically, someone will send in a balance bill and they still owe deductible, or it went to coinsurance, and they just don't understand the plan. So we're receiving very few and paying, having to pay a negotiated rate even on fewer than those. And the no network access fee allows our pricing to be extremely competitive. So that's kind of what makes our under 65 products very competitive. This gives you an idea of reference-based pricing and how it works. So this was on an MRI, and it was a person that was billed $1,060. Medicare allowable for that bill is $222. Reference-based pricing at 125% is $278. If the deductible was met, they would have to pay the 80/20, which would be about $55.69. If the deductible wasn't met, that whole $278.40 would go towards the deductible, and the insured would be responsible to pay it. Still a very big savings in out-of-pocket expenses. This chart shows you where there's arrows. It shows you where we have products on that 4x3 plan. So a 4x3 plan is a duration where we issue 4 90-day policies at one time. There's no new medical underwriting and no new pre-ex and no new waiting periods for policy 2, 3, and 4 of that 4x3 plan. It allows the insured to have 360 days of consecutive coverage. So those are the states where we sell the 4x3 instead of just a 6-month plan. And then you'll see the 364-day states. This gives you an idea of pricing on our plans. So remember I said the Choice $5,000 deductible was our most competitive plan. It's the one we're selling the most of. And the rate there, is $377 on this example. If you look over at the Deluxe plan, which is our second best-selling plan, because it most looks like an individual plan because it does have the doctor office visit copays, has a low coinsurance pocket at a maximum, and also has the RX coverage. That goes for almost double the core plan. So you're seeing that it's a little bit more expensive. But if you look at that core plan, you'll see it's almost priced as much as the Choice plan. And that just represents the network pricing that's involved when it comes to those plans. So that just gives you an idea of plans and premium. The process is really simple. Once you're contracted, you receive a unique URL to use for all your sales. As I'd mentioned, everything is electronic. The application is electronic, and so is fulfillment. So there's 5 simplified underwriting questions. The applicant answers no to all the questions. They're issued on the spot. It's accept or reject underwriting. It's e-signature for self-service. The applicant can be 6 months to 64 years and 11 months. It's immediate issue. Now there are waiting periods that apply. There's a 5-day wait on sickness and for prescriptions, and there's a 30-day wait for cancer. This gives you an idea of the underwriting questions. Number 2, the third one down, we only care how heavy you are. We don't care how tall you are. So there's no height and weight chart. It's just if you're over 300 pounds and you're a male, or 250 for a female, you would not be eligible. And then number 3, of course, is the big question where we asked in the last 5 years, have you had a diagnosis, symptoms, abnormal test results, received treatment, medication, or consultation for any of the conditions stated. And then lastly, we don't ask for Social Security number. So if you have an individual that's here on a working visa or a school visa, as long as they've lived in the United States in the past 12 months, they can receive coverage. They can answer no to that question. As you guys, I'm sure already know, short-term health plans do have pre-existing limitation provisions. So there may be conditions that are not covered due to prior, treatment or diagnosis or care. And usually it goes back 60 months. That is state-specific. Some look back 12 months. To give you a little bit of an idea of who's buying these products, our demographics, male versus female primaries is about the same. 32.7% of our primary applicants are over age 50, and 10% are under age 20. So if you ask, do you think that child only down to 6 months and covering high school and college athletes is a niche for your products? I would say yes, based on our applicants and the percent of coverage of those applicants we have covered. Average premium is about $200 a month, and average persistency before the 364-day plan. So when we had the 4x3 plans, they were 6 months. This gives you an idea of our top selling states. You'll see, Texas, of course, is number 1, Georgia, Illinois, and Florida. Very competitive in all of these states. Our number 1 selling plan is the Choice $5,000 deductible. Our Choice plan itself is our number 1 selling plan, Chevron, by far. And then you'll see Economy, which is kind of your bare bones plan. There's no doctor office visits. There's no prescription drug rider. There's just a discount card, but very good, benefits. It's just kind of, I want to know if something happens to me, I have insurance. So it's kind of your bare bone plans. And then the deluxe plan, of course, is going to be more expensive. So what we're super excited to talk about today is a brand new plan that we came out in the market. It's called the Bridge to Medicare plan. Now this Bridge to Medicare plan, why did we come out with it? What makes it different? Well, if you're working with pre-65 individuals, you know that this is a market that's very underserved. So if this market, most of these people in this age group between age 61.5 to 64.5, which is about 28% of the population, or 12 million baby boomers, they're not getting, most of them are not getting a subsidy. And they have nowhere else to go. So there's not really a plan for them if they're not getting a subsidy or that they can go to. It's basically they go into ACA. That's the plan they go to before they turn 65. We hear every single day, all the time, we have heard for years, 10,000 people are turning 65 every day and will continue to 2030. Well, with that, 10,000 people are turning 62, 63, and 64 every day. So again, this is a huge market that people kind of, if you sell under 65, you don't want that age group because you think they're too old. And then if you're if you're working over 65, they're too young for you. There's nothing you can do with them. So We just felt like there was a big hole here where we could find a product to help them. And from just looking at our current membership, 12% of our members are 60 plus. So that told us there was a need. It told us that these people, this age group, were getting through the underwriting questions. So we have about 70 to 72% of individuals, applicants in over 60 that come and do an application actually are accepted and get coverage. So we saw the need there. So the problem, those that they're not getting subsidy, ACA plans are very unaffordable. The lifetime value of a sale for ACA plans is very low for the agent. ACA persistency is very low. Customers are forced to shop every year due to carriers pulling out, networks getting smaller, plans are changing. ACA carrier options are getting smaller and smaller. We are getting to kind of, I think, where ACA was trying to go in the very beginning, where it's getting very close to a single payer. And then again, it's lead aggregators. If you buy leads, you know that it is very hard to, and no one wants a lead that's between 61 and 64. They just don't want it. There's nowhere to put these people. So we thought if we brought this product to market, we could improve coverage for the individuals that are in between the pre-Medicare stage. We could increase the lifetime value for the agent. We wanted to offer value to that customer right away. So we wanted to be able to give first dollar benefits to the member right away without having to satisfy a large deductible and co-insurance. They can go to the doctor and get reimbursed for going to the doctor. It allows for the agent or agency to have a lower acquisition cost for that Medicare lead, because you get them when you're 62. It's just the next progression to roll them into, whether you're doing Med Advantage, Med Sup, or PDP plan. And again, it's very simple to do. So this just gives you an idea of what a comp would look like. This is an average comp. So what we do is we pay on both premiums. So the Bridge to Medicare plan is actually two plans. It's a short-term medical plan and a limited medical benefit plan packaged together. So it's already packaged for you. You don't have to put the two together. It's already there for you. Buy both at the same time. And what we do is we pay a flat commission on the short-term premium, and then you get a graduated commission on the limited medical benefit plan. But it brings that lifetime value up for the agent. This gives you an idea of the premium. So when we came up with this product idea and we wanted to make it a 3 by 12 months or a 3 by 12, we knew there was going to have to be some type of rate put on that pre-existing waiver for policy 2 and 3. So we knew it was going to be more expensive. So if you look at this plan and you look at just a short-term medical plan next to it, it's going to be more expensive. But that wasn't what we were going against. We wanted to be 35 to 40% lower than ACA. So we said we want this age group to be able to have a very substantial rate reduction by being healthy and being able to get into the plan, not getting a subsidy. So that's kind of the benchmark that we were going towards. The product was filed and has been filed in 364 states. And as you know, over the past couple of months, those 364 states have changed multiple times. So today we have the plan available in 8 markets. These are the markets that are available. You see we have some pretty big states: Florida, Georgia, Texas, Ohio, and Pennsylvania. These are all a part of our top 10 states. And just to let you know, we have 3 states on the horizon that we think are going to be fairly come about very shortly. One is Virginia. The other is Tennessee. And then another one is Arizona. where we are filing there and we feel that we're going to get this plan available there. So those are the 3 states that are coming. So let's look at the plan design. There are 3 plans. This is the short-term medical benefits, okay? So when someone is issued, they will receive 1 ID card. The provider will file 1 claim. That claim will go to Allied, our administrator, and what Allied's going to do is they're going to look at the short-term medical benefits first. And they're going to say, okay, you know, this is going to be, we're going to take it through the reference-based pricing. We're going to discount it or reprice it based on the reference-based pricing. We're going to go ahead and apply the deductible and the co-insurance and any the other benefits. Then once it goes through the short-term policy, it now is going to go to the limited medical benefit plan. And you'll see that the plans coincide. And then we're going to see, are any of those services, are they on a schedule where they receive a reimbursement? Regardless of what happened on the short-term policy, if it's a covered expense and it's one of the services that provides a reimbursement, it's going to be reimbursed exactly how the schedule says. So the claim, maybe after it was repriced, it's going to be lower than what the benefit payout is for limited benefit plans. They're going to get paid that amount no matter what. So as long as it's covered services. So you'll see here, we said, okay, let's look at the services that an insured probably uses typically most often. You know, go to the doctor. You get $85 for 6 visits on Plan 3. Have a preventative checkup. You can do 1 a year. It's $150. You know, go to physical therapy. Go to the chiropractor. Outpatient diagnostics. All of these are reimbursed. The payment is paid directly to the insured to offset any out-of-pocket expense they have. So it's 1 ID card, 1 claim, 2 policy benefits. When you're quoting the Bridge to Medicare plan, you'll see the 3 plans would come up. And then you go right into the application from here. And again, everything is online. Now you're seeing 1 premium. When they get to the billing premium, when the billing page, it's going to separate that premium out. It's going to have your short-term medical premium and then your limited benefit premium. And then, so every month that insured is going to be charged twice. The total amount will equal the amount that they see, but they're going to have a short-term and a limited benefit. And those 2 charges are going to show on their card, on their statement. There's a one-time enrollment fee, and it is only charged on policy 1. It's not charged on policy 2 or policy 3. And again, the person doesn't have to be 62. They can be 63 and get a 2-year benefit. They could be 64 and get the benefit, maybe they want the limited benefit reimbursement and they just want the lower cost plan compared to ACA. The policy will automatically turn on the month or the day they become eligible for Medicare, which is the first of the month that they turn 65. So it's automatically going to turn then, and then they can just go right into Medicare. This is an association filed plan in most states. So with that, the plan comes with some extra benefits. It comes with a prescription drug discount card, comes with a vision discount through Davis Vision, and it also comes with an audiology discount through American Hearing benefit. And that is a discount on hearing exams and hearing aids. There is also a doctor on demand benefit to this. So if they call a doctor, they can call a number and do a doctor on demand, which basically is FaceTiming a doctor. That is a $49 charge. That's not part of their insurance plan. This is an extra plan they get through the association. If they use that doctor on demand, they do that FaceTime with the doctor, they're going to be charged $49. If they send that bill into Allied, they'll be reimbursed that complete $49. So it's basically a free visit. It doesn't go towards their reimbursement from the plan. It doesn't go towards their deductible. It's basically an extra benefit that they get through the association. So that's something nice for this age group as well. How the products are found, once you get your URL, you will see a product link. That product link will drop down, and Bridge to Medicare will be a product that you can click on, where there you would start the quoting. It will automatically default to your short-term products, so you do need to click the Bridge to Medicare link to get to that quoting for the Bridge to Medicare. Those are our products. I kind of went quick over the first two products because they have been in the market, and hopefully you've been kind of introduced to them before. If not, Sue, I think is going to be taking some questions that we can answer, but really wanted to focus on the Bridge to Medicare product. We're super excited about the product. I'm sure that, you know, you've come across many clients that you have one spouse that's turning 65 and the other spouse really has nowhere to go because maybe they don't get a subsidy and the person's healthy, so they only can go to ACA. So this gives you an option for them, hopefully in the 8 states that we have available today.